Hello everyone, can you hear me?
Yeah.
Mm.
Is the screen visible? Can you see the screen?
Happy Tasty.
Hmm. Let's start our first case then. This is a 40-year-old male admitted to the emergency department with high-grade fever and productive cough. His hemoglobin is 120, white cell count is 70, and platelet count is 210. This is power 10. And I will go now to power 50. Do we have any lab scientists in the audience? Okay. If there is no lab scientist, for example, I am the lab scientist. I have seen this blood film and reported as leukocytosis with NRBC, likely CML. Refer this blood film to clinical hematologist. You are the clinical hematologist and you have to report this blood film. So first on the list is how many Godwin? How many, if you have any comments on this blood film?
Okay, yeah, let me take a shot at it. Can you hear me?
Hello. So do you have any comment on this blood film?
Okay, sorry, please. The brief history again. Sorry, my
Oh,
kids were
history.
disturbing.
This is a 40-year-old man admitted to the emergency department with fever and cough. The full blood count shows hemoglobin of 120, white cell count of 76, and platelet count of 220. Lab scientists have seen the blood film, and he has reported as leukocytosis with NRBC, likely CML. The blood film referred to hematology, clinical hematology. If you can report this blood film as a clinical hematology.
So the red blood cells. Uh, so the red cells, I would say aniso anisocytosis. Um, they are nucleated red blood cells, nucleated RBC for the red cell, and then for the white cells, I would say leukocytosis with complete myeloid spectrum, and for the platelets, so for the platelets, I'll say the field I'm looking at now, the platelet appears reduced on film, but they not, yeah, yes. And that's what I can appreciate here, yeah.
What is your impression?
So my impression with this would be CML.
And what suggestion you will give to the team? Because they will contact you shortly from the ED that the patient has high white cell count. Is this a leukemia or what is this?
Oh, this looks like this CML. So I'll go with CML. So for this, the immediate care for this patient would be uh, I could get some cytoreductive for the patient while waiting to get a more definite diagnosis. So I could give some hydroxyurea, give hydroxyurea, and then ensure patient is hydrated. Then give allopurinol to prevent in case of TLS. And then for patient having fever, so we could also do the septic workup, get a chest X-ray, uh, do the blood culture, get the full blood culture, do urine culture, and then start patient on antibiotics. Um, yeah, so that would be the immediate care for this patient, and then eventually we will try to get a more definitive diagnosis. Although for CML, we could still send blood samples for fish to get the BCR ABL, but we will still need to do a bone marrow so as to help us do the staging properly and also for cytogenetics. And then for this patient, we also need to look at other comorbidities. Is the patient diabetic? Does the patient have any cardiac concerns? Because that would eventually determine the treatments that we would offer this patient.
Okay. Is there anyone in the audience who disagree with Omni Godwin? Ravia, what do you think is Omni correct in reporting the blood film? Azza, Azza Rajab.
Hi, Amish. Um,
Uh, do you agree with Omni Godwin or do you disagree with Omni Godwin?
yeah, I think I saw a couple of blasts, but just I would like to see more um like sides of the film just to decide like if it's like in blast crisis or not. I agree that it's CML is a probability, but obviously we need to make sure that there is no significant number of blasts, like it's not in blast crisis. Um, so far in this field, I can see like it's. I agree that there is variation in the granulocyte at different maturation stages, with mainly myelocyte peak, many nucleated red cells in this field. Um,
Is there anything missing in this blood film?
basophils,
If you are saying that basophil is missing, then why are you saying that this is blast crisis or CML?
yeah, I couldn't appreciate any. Yeah, there was no basophil as far as I can see. Yeah, yeah,
Did you see any eosinophil?
no, 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 I couldn't appreciate any basophil or eosinophil.
Yeah. So then, what could it be if there is no basophil, no eosinophil, and there is myeloid peak, and this is the picture?
Yeah, um, really combined reaction.
Hmm? Yes. Patient has sepsis.
Yeah, there is definitely left shift neutrophilia.
So this is the common case that appeared in the FRCPath Part 2 exam, and people write it as CML. Both leukocyte reaction and CML has high white cell count, but the difference is basophilia and eosinophilia. You didn't see any basophil here. You didn't see any eosinophil here. Also,
Yeah,
all other components of myeloid series are present here with NRBC as well. And the patient is febrile, having uh, pneumonia symptoms. This is a septic blood film, not a CML blood film. For CML, you should see eosinophils, you should see basophils as well.
yeah, that's true. Yeah,
Okay. So, reactive blood film is a must thing in the exam, and people write it as CML. Okay. So, you need to see uh, blood films of septic patient in your hospital, and also the CML patient blood film as well, so that you could know what is the difference between the two. Okay. This blood film contains a lot of NRBC. There is N-acetocytosis. We could see many teardrop cells. Here in this picture, you can see target cells as well. There were few whole jelly bodies in the red cells. There is myeloid peak in the white cell. Okay. You can see all sort of uh, myeloid series here. Platelet count is low, which is low because patient has splenomegaly, as evident by the target cells and by the whole jelly body. So this was the septic blood. And the same patient presented to hematology department after 5 years. Okay. The GP referred the patient to hematology department because of persistent leukocytosis. This is his blood film. This is power 10. His full blood count shows hemoglobin of 105, white cell count of 400, and platelet count of 100. Okay, now I will go to power 50. Okay. So what do you think about this blood film? The same scientists have seen the blood film again, and he says that this patient has leukocytosis and likely leukemia. The blood film has come back to you again. Now you have to report it. Radia, are you there? So Radia is hiding today. Uh, Next one is Rasha Guda. Okay, Samir Abbas.
Hi, Amir.
Hi. So
I can still see like very large number of left shifted granulocytes with all stage of maturation, and I think it is still with some like roll formation in the background as well, which might be like suggesting possibility like of a severe infection again. I couldn't appreciate any basophils or eosinophils still in this film, so I would still go with
what is
glucomoid
this?
reaction.
Can you see my
Oh yes.
this one?
Oh, this is an
There were
base.
many things like this in this blood film that we have seen.
Is that a basophil?
This is a basophil.
Hmm.
Basophil is a very, very granular structure, and there are many like leukemoid reaction. will not give you white cell count of 400. This is
No,
another
that's
basic. This is the basic. This one, see, thick granule. This
yeah.
this film is full of basophil.
So now this is a CML.
This is a CML, but we don't know whether this is blast crisis or chronic phase. How would you differentiate, or
So
what differentiates between the two?
so the blast percentage is the most important here.
Mhm.
Um, we don't have now in the classification anymore the accelerated phase, but which will be like a 15 to 29% of blast, and if more than 30%, it will be blast phase. Otherwise, it will be chronic.
More than 20% blast. If you have now in CML, you will treat it as AML. Okay, so for CML and for the SEPA mutation, BCR-ABL, and for SEPA mutation, you need more than 20% blast to treat them as AML. For others, if you have just mutation or translocation present, irrespective of the blast percentage, you will treat them as AML. This is according to WHO 2022.
Okay.
All right. The chronic phase, the blast count is how much?
I think then it will be anything less than the 19, 10 to 19%.
Yes, because now the accelerated phase has been removed.
Yeah.
So anything less than 20, we consider as in a chronic phase. Previously, 10 to 20 was accelerated and less than 10 was chronic, but now most of the hospitals in UK, they use WHO 2022. What are the major root abnormalities in CML?
Was it the KRAS?
There is no KRAS in CML. Anyone who knows which are the major root abnormalities in the CML
Trisomy 8.
and others?
There's also complex.
Additional Philadelphia chromosome.
Extra PA, trisomy 8, 19, trisomy 19, and isochromosome 17 are considered as major root abnormalities. Okay, what is the prognosis score that you use in your hospital for CML?
The ALT score.
ALTS score. If ALTS score is high in this young patient, which medication you would like to offer to this patient?
Second generation TKI, like the Satinib.
That's certain. High LTS, young patient, you can offer them second generation dasatinib. What are the contraindications of dasatinib?
I think pleural effusion, pulmonary edema, or pericardial effusion.
Yeah. Anything which desaturates is the contraindication. Uh, sorry,
Contraindication for the desatinate period.
desatinate.
Um, I believe
The
if I've
D,
got already pulmonary or pericardial disease, for example.
yeah. So D for desatinate, D for desaturation. Anything which desaturates the person
Mm.
means cause hypoxia, can lead to, or the contraindications of um, desatinate.
Right. Yeah.
So now this is 20-year-old female. Uh, who presented to ED with fatigue. Okay. The full blood count shows hemoglobin of 90, white cell count of 4, and platelet count of 1050. The lab scientists have reported the blood film as thrombocytosis, likely essential thrombocythemia. The blood film has been referred to you for your comment. So this is the power 10. Now I will go to power 50. Okay. Any comments from your side? How to report this blood film for the exam purpose? Fatima Shakar?
I think I will say RBC is showing an esophagocytosis um, with some um, with
Mm-hmm.
okay. Um, I think in the previous film I appreciated some pencil cells, but I can't see them here. Um, um, there are occasional fragments.
Mm-hmm.
Okay. There is some mild platelet clumping
Mm-hmm.
platelets, anisocytosis. Yeah, so here there are some I think there are some pencil cells here in this field.
Mm-hmm.
Um, there are few cells lacking the central pallor. Looks, I don't want to commit myself to spherocytes here, but yeah, and mild thrombocytosis. Um, lymphocyte. So there is lymphocyte in the middle here, and if we compare the size of the red cells, it's slightly microcytic. Um, yeah, so I think I will say feature suggestive of iron deficiency anemia.
Do you think this is iron deficiency anemia or combined deficiency or this is ET?
So the cell sizes, some of them are some of them are smaller than the size of the lymphocyte nucleus, but there are few a little bit bigger cells like this one on top here, yeah, and another one here at the middle. So it could be mixed, yeah, you're right.
It is not ET?
I don't think so. Well, I can't say for sure, but because we need to do further testing, check the iron stores, check the inflammatory markers. Um,
Mhm.
and if all negative, then I can check the JAK2 mutation and the color. Um, yeah, but initially we need to exclude reactive causes.
Okay. Your approach is correct. But first, they have to exclude the methane deficiency and the infection marker. If they are normal, then we have to send blood to SMBS or or MPN.
Yeah.
Yes, this blood film has a lot of N-astrocytosis, both microcytic, macrocytic cell. Uh, one of the cells has whole jolly bodies as well. And I bring out this lymphocyte for you so that we can compare the size of the RBC with the lymphocyte. And she is a female and can have menorrhagia as well, leading to iron deficiency anemia. So yes, we cannot jump straight to ET. We have to exclude iron deficiency and infection first, according to the BSH algorithm, to exclude the reactive causes first. For
Yep.
example, this patient was diagnosed as ET. What treatment you would like to give to this patient?
So she is a young lady. I need to check her if check if she had any previous history of thrombosis um, or yeah, VTE before.
No.
If no, so if not, she's then that means she's low risk. So I will start her on aspirin and keep monitoring her counts. No need to start cytoreductive therapy at the like currently.
Better to check your hospital guidelines whether they would like to give aspirin or not, because her platelet count is about 1,000. I've seen some of the trusts do not give aspirin if the count is about 1,000. Some of the trusts do not give aspirin if the count are above 1,500. So check your hospital guidelines or discuss with your myeloid consultant. If they say yes, we will give, then okay. If they say no, then in the exam you can mention to them, according to my trust guideline, they usually avoid aspirin about when the platelet count is about 1,000 because of the risk of acquired 1 milligram syndrome. So practice practice varies in terms of aspirin, but below 1,000, yes, everyone will get aspirin and no indication of cytoreductive therapy. So this is 70-year-old man presented to ED with a large neck mass on the left side of the neck. CT scan, neck, abdomen, pelvis shows lymphadenopathy above and below diaphragm. The full blood count shows hemoglobin of 110, white cell count of 12, and platelet count is normal. He has weight loss, night sweats, and lack of appetite. The neck mass is quite big and it is causing discomfort to him. This is forward 10. I'll go to forward 50 now. There are some droplets in the slide. Ignore that. So I have seen this blood film as a biomedical scientist, and I have labeled this case as a lymphoma because of these abnormal cells in the patient lymphocyte uh, in the blood film. I don't know about the history of the patient because we do not have access to the patient record. I was trying to preserve the blood film by keeping a cover slip on it, and this has created all this. Please ignore. So when I saw this cell, I thought this is some kind of lymphoma. I should refer it to clinical hematology. So you know the story of the patient, and this is the blood film. Next on the list is uh, Iman Sayed Ibrahim. Iman Sayed Ahmed Ibrahim. She is silent. Then we have top on the list is Doc, 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 Dr. Aisha Shahid.
Yes, here.
Yes. So what do you think is going on with this patient? The biomedical scientists think that this is some lymphoma in this patient. He has not mentioned which lymphoma, but after seeing these cells, he think that maybe there is lymphoma in the patient.
Okay. Mm, these cells are large, and maybe it could be a leukemia too. I don't know the exact count of the cells. I don't recall the DLC.
13. White cell count is 13.
13.
Hemoglobin is hemoglobin is 105. Platelet count is normal.
And the age of the patient is?
70.
Is there any history of fever?
Patient has no fever, but he has a history of weight loss, history of night sweats, and he has a big neck mass.
Okay. Um, what is the ESR of the patient? And
We don't do ESR here. If you want
okay,
to
so
ask
I'm sorry.
anything,
Um, I would like to rule out plasma cell or plasmablastic. Uh,
this is your blood film. You have to report it.
okay, so the WBCs show large cells with abundant cytoplasm and few vacuoles, and nuclei also prominent in the large nuclei.
Mhm.
Um, I could not decipher how many these cells are because it really counts. I would like to know the exact DLC, because if these cells are like around greater than 10% or greater than 5%, then I would, because these are very big, and they are definitely not reactive lymphocytes. They are little more bizarre looking than those.
They have some
So
skeleton here.
yes.
Mhm.
And I wanted to see whether there is rouleau formation, but I don't think there is any rouleau formation on the smear. And the RBCs are showing some kind of maybe some kind of fixation defect. Uh, some the and the platelets look normal. So I'd like to advise flow cytometry on this since the patient has a mass in the neck. So, and also there should be FNSE or biopsy of that mass uh, to rule out any lymphoma or
What do you think?
solitary neoplasm.
What is your impression? Yes, you have commented on the blood film. You have give your plan as well. But what is your impression?
I don't know, but I had seen one case of plasmablastic leukemia somewhere, and I don't know why these cells are reminding me of those cells. I have no idea, but somehow it is giving me that sort of look.
Plasmablastic leukemia come with a mass?
Come, no, just the cells, just the cells. If I'm just
Okay.
looking at the cells, then it's giving me that sort of thing. It's very big and they're very aggressive looking. Could be DLBCL, but the DLBCL does not have so much cytoplasm.
Mhm.
Or anaplastic large cell could be one of the differentials.
You would see anaplastic large cells in the aspirate or in the defined. They rarely appear in the blood.
Yes, fine, true.
Okay, so the flow cytometry results have come back. It is CD5 negative, CD7 negative, CD10 negative, CD19 positive, 20 positive, 23 negative, 43 negative, BCL2 positive, BCL6 positive, TP53 positive.
Okay.
Mid-88 is positive as well. You have the full immunohistochemistry result.
Yes, DLBCL.
Oh, so you think this is DLBCL? No.
Yes.
These are not blast. You can see the size of the blast with the surrounding RBC, and some of them have a single prominent nucleoli, or some of them have two prominent nucleoli, or more than that. Okay? And if a patient has a big mass in the neck as well, that is telling you that it can be a high grade lymphoma, because Burkitt lymphoma or DLBCL with always present with huge masses either in the groin or in the tummy or in the axilla or in the neck, compressing other structures and keeping the patient in agony, and the mass appear very quickly in a matter of days because they are aggressive lymphoma. If the mass appear over months and the cells in the blood film are small as well, small to medium size, then I may think that maybe this is a low grade lymphoma.
Hmm.
But these lymphocytes are quite big with a very prominent nuclei in the center, as you can see in this picture. You always worry for a high grade lymphoma. If it was a Burkitt, Burkitt has different morphology. Uh, their cytoplasm is very deeply basophilic if they involve the blood film with some maculation as well. Uh, so this patient age is 70. LDH is 5,000. He has a lymphadenopathy above and below the diaphragm, and his performance status is 2. Do you think which regimen of therapy he would be fit for?
Are you asking me?
Yes.
Um, I'm sorry, I do not remember the drugs right now.
Okay. So anyone else? If this patient is aging 70, LDH is 5,000, he has a disease below and above the diaphragm, his performance status is 2. What regimens do you have in UK to offer to this patient? I would ask Ravia or Azza. Okay, Samir, you can talk if you have the answer.
I was thinking that maybe his IBI score could be 3 plus
Mm-hmm.
because of the age and the high LDH and the performance status. And then,
Mm-hmm.
and he's double hit. So we can give him R chop, like, mm, um, or or R or polar R chip.
Mm-hmm.
Plus, we can consider like the radiotherapy to the neck mass to reduce like the symptoms of the pressure.
Mm. Radiotherapy is an option here, but because of many vital structures, uh, people may avoid it. They would like to see the response to chemotherapy first. Because if you offer him any chemotherapy, um, the mass reduces very quickly. But if it does not reduce, he failed the chemotherapy, then we go for radiotherapy of the neck. So what regimen do you suggest? Orthop or polar orthop? You mentioned
I
his
think
IPR is more than 3. So in high IPI, you give them polar orthop. If the IPI was 0, 1, or 2, then you would have offer orthop. This patient has no other comorbidity, so he can take polar orthop with high IPI. There are two other things about which we need to be careful in DLBCL or in this patient. What are they? And we consider them in every DLBCL patient.
CNS involvement, or if they were like high risk for that.
Yeah, CNS IPI you have to calculate. And second, TLS prophylaxis, because these patients they have high uh, tumor burden and they can go into TLS very quickly. Alright. Do you have any question?
No, thanks.
No, if no question, then we can stop here.
Sorry, just a quick one, please. I had
Yes.
got the main question on the last one. So sorry to take us back. For the patient with ET, low risk ET, and a young patient,
Mhm.
if we're thinking of acquired von Willebrand, so what would we not offer the patient since we won't be giving aspirin?
So if the patient has ET and can you please repeat from
Hi.
here?
So ET, young
Mhm.
patient less than 60, high platelet count, and we are bothered about acquired von Willebrand disease. So what would be the treatment option?
So the risk of acquired von Willebrand is high most if the platelet count is above 1500. In
Yeah.
that case, you can give this patient cytoreductive therapy
Okay.
because
Yeah.
you will not always follow what is written in the guideline. The case scenario sometimes get different according to the clinical situation. If this patient platelet
Okay.
count is for example 2000, I know that he can bleed she can bleed anytime. I will start to reduce the patient because without cytoreduction, you cannot reduce the platelet count of the patient.
Okay.
In such cases, you offer them cytoreductive therapy.
Okay. Thank you.
and then you avoid the aspirin as well. In our trust, we usually avoid aspirin if the platelet count is above 1,000, and
Okay.
because we are at high risk of um, bleeding related to acquired vulnerable.
Okay. So still in a young patient. So once we've been able to cyto reduce this patient, would we continue it long term, or would there be option of stopping it after some point?
Can you please
I don't know
repeat
if
the
you got my
question?
question. So
Can you
I'm
please
saying
repeat the
that.
question? Mm-hmm.
So I'm saying yes. We know that for younger patients, we would usually want to opt for aspirin. Yes, in this patient because of the high platelet count, we opted for cytoreductive to reduce the platelet count. So we've had the platelet count going far less than 1,000, maybe in 600 thereabout. Would we still carry on the cytoreductive long term, or at some point we get to stop and only give aspirin?
If the platelet count is 600 and patient has no VTE, no hemorrhage related to the ET, you only give them you only give them aspirin if the patient is young. If the patient has any if the patient has any VTE event, or if the patient has any hemorrhage related to ET, you will start you will start cytoreductive therapy even at low plate low platelet count as well.
So what I'm
And we
asking, I'm not talking of a new patient. I'm
Mhm.
saying the patient that initially had cytoreductive, then the
Okay.
platelet has now gone down to 600. So are we to carry on with the cytoreductive, or we get to stop at that point?
Yeah, so once the platelet count is in normal range, 150 to 400, at this stage we can pause the hydroxycarbamide and see whether the patient can maintain the platelet or not. If the
Okay.
platelet count start to rise again, we reintroduce the hydroxycarbamide. Because if you continue hydroxycarbamide, it is cytoreductive. It will continue to destroy your red cells and platelet, and it may go down dangerously low. Because if you open the hydroxycarbamide algorithm in the BSH, they have mentioned if your platelet count goes down below 100, or hemoglobin goes down below 45, our neutrophil count goes down below 1.0, you have to stop the hydroxycarbamide and you have to repeat the full blood count after a week. And if they are above these values, you can reintroduce hydroxycarbamide with a lower dose. So once they reach the normal values, you can give a pause. But we know that we follow these patients regularly, and uh, we check their full blood count every month, or in the control patient every 3 months. If their platelet count increase again above 400, we will start a small dose of hydroxycarbamide again.
Okay.
So if you open the hydroxycarbamide algorithm in the BSH, we always manage our um, patient hydroxycarbamide according to the guidelines for hydroxycarbamide, and this is the algorithm. In any case, if it is a polycythemia, if it is ET, if it is any other MPN, we follow this algorithm. Where is that? This one. It is on the screen.
Okay.
It's a neutrophil count less than 1.0, platelet less than 80, hemoglobin less than 45. Stop hydroxycarbamide and repeat full blood count weekly until neutrophil is above this level, platelet above this level, hemoglobin above this level. Once a stable dose is established, etc. So this is the hydroxycarbamide algorithm that we follow in our MPN patient, all MPNs.
Okay.
Okay.
Right. Thank you.
Okay. If nothing else, then we will see you next week. Thank you.
Thank you
Take care.
Thank
very much.
Thank you.
Thank you.
Take care.